onset is usually insidious over weeks to months, but very, very rarely it can also be an acute presentation. Like I said, there's first involvement of the lower extremity and then the upper extremity. Ocular muscles are almost never affected. Distal musculature is spared right till the end. Pharyngeal and neck muscles may be involved, and this may lead to dysphagia, dysphonia, head drop, etc. Then we have the primary idiopathic dermatomyositis, in which we do have whatever I've talked before, mainly proximal muscle weakness, along with typical skin lesions present. And these are the Gottron signs, the heliotrope rash. There is diffuse localized erythema present over the chest and the neck, which is called the shawl sign, or there even may be some pigmentation present on the forehead, the chin, the malar areas, and this is dreaded because there are underlying malignancies which may antedate or postdate dermatomyositis by about 2 to 3 years. These are the Gottron's signs. You can see these reddish violaceous patches present on the knuckles. The typical heliotrope rash, this violaceous kind of a rash present on the upper eyelid, may and may not be accompanied with edema. Again, Gottron's papules and the heliotrope rash. And there is yet another variety which is called amyopathic dermatomyositis. Now in this we only have the cutaneous manifestations of the disease, and there is normal muscle strength, normal enzymes, normal EMG and muscle biopsy findings. We may come across some additional skin signs, skin involvement in the dermatomyositis variety, pruritic scalp, Holster sign or erythroderma, cuticular hypertrophy, periungual erythema, and mechanic's hands. Now this is another subset in which there is myositis associated with an associated connective tissue disorder, and the overlap might be with SLE, rheumatoid arthritis. They may be present more commonly in childhood dermatomyositis, and in this variety the onset is usually rapid. The symptoms tend to develop rapidly, and the constitutional features, they are more marked, which may be low-grade fever, fatigue, myalgias, etc. So we have to be on the lookout when a kid presents with these features. And then we have another entity, which is the inclusion body myositis. It usually presents in the elderly population. Males are more commonly involved as compared to females. It is usually asymmetric in distribution. Weakness is mainly distal as compared to polymyositis, where the weakness is mainly proximal. The motor skills are involved earlier on in the disease. It is very, very slowly progressive. There may be tenderness present, and unfortunately tends to be rather refractory to treatment, and the muscle biopsy is characteristic in the sense that it shows vacuoles. We'll be coming to that in a while. I hope this is clear enough. A slide that shows some differences between the two, the inclusion body myositis and polymyositis. Here this is mainly male predominant as compared to female predominance. This is rare before 50 years, whereas this is common before 50 years. Onset is very, very insidious. The onset over here is usually, insidious, but it can be acute or subacute as well. This is very, very slowly progressive, and this is more rapidly progressive as compared to this variety. The distribution of weakness is variable, but primarily it is distal as compared to the proximal involvement in this variety. The creatinine kinase is high, but it is very, very high in polymyositis. And the EMG findings do differ in the sense that there may be a mixed picture over here, whereas in polymyositis it is mainly a myopathic picture. The muscle biopsy shows inflammation and vacuoles and inclusions in this variety, whereas over here there is inflammation and fibronecrosis. And finally, response to therapy is poor, and in the other variety it is better. This is the distribution of muscle involvement in polymyositis, and this is an inclusion by the myositis. The diagnosis is made on the typical clinical picture, elevation of enzymes, typical EMG findings, and a muscle biopsy. Now, I'd like to just take a few seconds and describe an additional antibody profile over here. Like I said, if it might be associated with other connective tissue disorders, and if the ENA is positive, then there is a very strong overlap with other connective tissue diseases. Anti-DS DNA may be positive in SLE, scleroderma 70 may be positive